glad to see you here. It's my pleasure to introduce Dr. Pedro Cano for our seminar today. Dr. Cano is a candidate for the director of the HLA laboratory, and welcome to San Antonio. Yes, Dr. Cano got his education MD degree in Spain in 1983, did training for, additional training for an MBA in 1991 in economics and statistics at the University of Chicago Graduate School of Business. And then went and did residency training in clinical pathology at the Michael Reese Hospital in Chicago, Illinois. He was also a fellow in transfusion medicine at the Blood Center of Southeastern Wisconsin and Medical College of Wisconsin affiliated hospitals. And also at the same site did a postgraduate fellowship in molecular immunology, HLA typing, laboratory at the Blood Center, again in Milwaukee. He's certified in clinical pathology by the American Board of Pathology and also certified by the American Society for Histocompatibility and Immunogenetics, HLA laboratory director, and this was in 1991. He's currently the medical director for the Department of Laboratory Medicine and Pathology, the HLA typing laboratory at MD Anderson Hospital in Houston, and co-program director for the Histocompatibility and Immunogenetics training program, also at Houston. He's the author of numerous papers, largely devoted to histocompatibility and testing. He's a member of several national organizations as well. A sought-after speaker in terms of both national and international interest as it relates to transplantation, and has a bibliography, again, that really focuses on HLA transplants and other transplant kind of things. Today, Dr. Cano is going to talk to us on evidence-based medicine and transplantation, and so, Dr. Cano.
Thank you very much. Thank you very much. It's a pleasure to be here and have a chance to spend the day with you. Can you hear me all right? Let me see. Let's switch it. Okay. Okay. Can you hear me all right? Oh, very good. Very good. I don't think it is an exaggeration to say that we are living, maybe the word sounds very dramatic, but I cannot come up with a better word. The word is revolution in clinical thinking. I think that even though it has there has not been very dramatic arguments about it that everybody is aware of, but I think there has been some very significant changes in the last, certainly in the period that I have been practicing medicine. Let's go through some of these changes. The question is, what counts as evidence in medicine? When I started, medical school and residency, the value given to these sources of evidence that we use to make clinical decisions was different to what it is now. Of course, randomized clinical trials are not new, but certainly at that time, they were not as widespread or considered in such high regard as now. In the old days, physicians were valued for their clinical experience and for their knowledge of pathophysiological mechanisms and how they could apply this knowledge to clinical decisions and patient care. And also at the time, I remember there was a fashion to have consensus meetings in which experts met and decided what was the best course of action in different clinical situations. I thought it was crazy at the time when I mean, what are these guys, meeting, thinking that just because of their expertise, they can vote as if it were, science, I thought, had to progress in a different direction. Now, clinical experience and pathophysiological mechanisms have been devalued dramatically. And I have to say that evidence-based medicine proponents, although I think they are right in what they are proposing, and we are going to go through some of these things, they have not had very good manners, because I think it's very rude to say to an experienced clinician, your experience is good for nothing. The only thing that counts is the latest, clinical trial. So there has been some animosity in that regard, and there is some resistance from some clinicians saying, what do you mean? I mean, this is what I do with my patients, what I've always done, what the textbooks say and everything, and you're saying that all that is good for nothing? Well, there are some extremists that think that the only evidence that counts is randomized clinical trial. Of course, there are areas where it is not possible, particularly in transplantation. What I'm going to present to you today is not randomized clinical trials, because that is very, very difficult. It would be unethical, among other things, I think, to really develop a randomized clinical trials when you already know that some arms in your studies are going to be better than others. So most of the work that we deal with in transplantation is observational studies, both retrospective and prospective. So the main reason why I want to talk to you about this today is not because I'm in favor or against. That's not the point. The point I want to make is that we need to be critical about it. This is very important. What worries me most is to see people taking this kind of philosophy for granted. I mean, this is what everybody does. I mean, you go to a meeting, to the ASH meeting, and you see, or many other, all these Kaplan-Meier survival curves all the time, and nobody questions what is behind these curves and the reasoning behind, and that's what worries me. So the main message for me today to you is that we need to be critical, very critical, and I'm going to show you what I mean by that. And so this is the main message of my presentation, and I'm going to give you some examples about it. Now, what do we mean by evidence-based medicine? What is, the main thing, the main thing here is that evidence needs to be evaluated. So what is the criteria to evaluate the evidence? There are two aspects of it. How valid it is, which is an internal aspect of a clinical study, whether you are using the correct analytical methods. I mean, of course, you can have very good or very bad laboratory tests, and if your data is no good because of the tests that you're using are not good, then it doesn't matter how beautiful your statistic analysis is, if your analytical methods are not good. So you need to look at that. Of course, you need to pay attention to the data analysis, whether it's appropriate for the data set. And this is an area, again, that I very much regret that we as clinicians, physicians, or PhD, or whatever, we have delegated our responsibility to have control over the analysis of the clinic, of the data, to statisticians. It is, of course, I mean, I'm not. Statisticians are very valuable, and we need to turn to them for difficult data analysis. But we should, that is my position, we should develop some expertise in that analysis. It is a mistake. If we want to do clinical research, we cannot just depend totally on professional statisticians. We need to know the fundamentals of it so that we can be critical about it. And of course, the whole issue with this these different levels of value to the clinical evidence is, why is randomized clinical trials better than observational studies? Why are observational studies better than clinical experience? The reason is, it has to do with bias. The reason is that randomized clinical trials are better tools to detect and avoid different types of bias. I'm sure I know what you know what I'm talking about. We don't have time to go into that, but that's the main reason. Now, there is a second aspect in the evaluation of evidence in medicine, which is how relevant it is. One thing is how well the study is done and how valid it is. So you can you can have a very valid test, very well designed, with very strong data, but be totally irrelevant in clinical practice. So yes, I mean, you have demonstrated that this is important for this, that this is, these two variables, this intervention variable affects this outcome variable, but so what? So the outcomes must be relevant to the patient. For instance, I mean, the patient, at the end of the day, doesn't care, like, to give a basic example, his cholesterol levels. What the patient is interested in is his life expectancy, clinical variables like that. So in transplantation, we have to look at a transplant patient doesn't care whether he has antibodies or not. What he wants to know is whether how long he's going to survive, how long his graft is going to be tolerated, and things like that. So we need to evaluate when we look at clinical trials and studies about the relevance of the outcome studies. You can have a very, a dramatic effect on an outcome, but if that dramatic effect on an outcome comes with very significant side effects, then it's also questionable. So that's another thing to consider, that the benefits must outweigh the harms. Another problem is that a study may be done in a group of patients that is not relevant to the patients that you see. For instance, if you are a pediatrician, a study performed on adults may not be relevant to your patients. So that's another important question. Another thing is that the comparison between interventions must be realistic. Very often we see clinical trials and studies where a therapeutic intervention is compared to a placebo. Well, I mean, in some cases that may be very important, but in other cases we want to compare two viable options in therapeutic decisions. So these are the criteria to evaluate how good a study is. Now, this is a picture of how I see the overall problem here. There is an accumulation of clinical trials, and these clinical trials are reported in the medical literature very often with summaries of the data. So even at this point here, what we have access to is not these. We don't have access to them very often. I mean, I think we should. I mean, my main point is that we should have direct contact with the data coming from clinical trials. What we see is summaries of it. And then a number of clinical trial reports get put together in what they call systematic reviews, which are becoming very popular now. These systematic reviews are then used to design guidelines. And these guidelines, in particular institutions and departments, are used to write standard operating procedures that are followed. So as you can see, and we are here using standard operating procedures to make decisions with our patients every day. And you can see how detached we are from the actual evidence that is here. And I think this is a problem. We need to go back here and see what's going on. This is, you know, I mean, it affects many aspects of our lives nowadays, the bureaucratization of intellectual life and scientific life, that at all these levels, you have a number of committees that make decisions for us, and we are just following standard operating procedures. And I think in many cases, probably 90%, I'm just guessing the number, 90% or even 95% of the cases, this is a good system. But I can tell you, in extreme cases, this system fails. There is a point where all these standard operating procedures, it doesn't work in some cases. So we need to use, and the key here is to go back and have our own judgment about the value of these studies. Now, the main thing in clinical trials is survival analysis. I mean, most of these things are survival studies. This is a little complicated. As a matter, I mean, if you go to any meeting, this is the bread and butter of all the presentations, okay, these survival studies. Let me tell you, anybody who has spent time trying to figure out how to do these things will have to recognize that these things are very complicated. And we just, and these are very powerful tools that we use without knowing what they do. We have powerful, I mean, these are implemented in sophisticated statistical computer packages that we use without knowing what's behind, and that's dangerous too. So the data to be analyzed is timed to an event of interest, which can be death or can be recurrence of a malignant disease. And if these data were clear, clean, and straightforward, we would not need these sophisticated methods. Basic statistical methods could do the job. In some cases, actually, most of the things that I'm going to present to you today are simple enough that you don't need to use sophisticated methods. You can be better off using simple methods, and I will show you some examples. The problem is that these data, survival times, are not clean. Studies conclude before the event of incidence occurs in some cases. For instance, if you're studying survival, many patients, you're making a study for, let's say, 5 years, many patients are going to survive more than 5 years. So that is what is called censored data. They use the adjective censored to indicate that you are not following up to the end. I mean, it would be impossible, very hard to follow up. I mean, you will have to do a study for 40 years to see the survival time of all the patients in a study group. So because of these problems, and also that the data is not distributed normally, you need some sophisticated methods. Now, let me tell you about some very basic concepts that everybody uses, taken for granted, and everybody uses as normal, concepts. But I want to show you how difficult it is to understand what these things are. These are very useful and important concepts, but they are difficult to understand. Survival probability is the probability that an individual survives from the time of origin, is perhaps when a diagnosis is made or when the study is begun, to a specified time. What you are doing here is, the survival probability is the probability of cumulative non-occurrence. So even though you have an event in mind, what you are measuring here is not the occurrence of the event, but the absence of the event. This is an important concept. Hazard, on the other hand, is the probability that an individual who is under observation at a time t has an event at that time. It is the current incident event rate. This is difficult to calculate, so people very rarely use the hazard. What they use is the cumulative hazard, which is the integral of the hazard, the area under the hazard function. So you see the hazard, which is the current incident of an event rate, is a rate or a probability of having an event, and it's a function of time. I mean, if you have had a transplant, death or graft failure or graft rejection, it can be the event, and the probability of having that is a function of how long you have had the transplant for. This is very hard to calculate, although it is an important concept to calculate this, which is easier, which is the cumulative hazard. And the tools that I showed you before are the ones used to calculate this. And that's what it says. The area, you remember from high school that the integral is the area under the curve, and the curve is this function of the hazard as a function of time. The interpretation of the cumulative hazard is difficult, but perhaps the easiest way to think of this is the cumulative force of mortality, or the number of events that would be expected for each individual by time t if the event were a repeatable process. Okay? Now, this is what the cumulative hazard is. And now from here, you have two groups with different cumulative hazard, and the hazard ratio is the ratio of the cumulative hazard of these two groups. And this is, I mean, as you can see, there is calculus involved. What I'm trying to say to you is that these concepts are not very intuitive. At the end of the day, we use the hazard ratio to see, is there a relationship, yes or no? Yes, it looks like there is a relationship, because whether there is a hazard ratio of 1.3 or 1.4 or 1.5, those differences are not really going to affect, because it's for me, it's almost impossible to use that information in a rational way in making decisions. I mean, this is a very robust, and everybody, I mean, this is, so it is worth spending a day or two going through the details of it to figure out what it is, because this is how every study nowadays is reported, the hazard ratio. But as you can see, the hazard ratio is the ratio of two cumulative hazards, and the cumulative hazards are the integrals of the hazard. I mean, give me a break. It's almost, I mean, this is beyond normal human intuition. It's very difficult to understand. And it takes a lot of thinking about it. The only way I can figure out how to take care of this and to become familiar with this is to do using these statistical packages that calculate, they use the Kaplan-Meier, the log-rank test, and the cost regression. The cost regression is the main tool used to get the hazard ratios. And to do simulations, like here, let me show you. Like here, I mean, this is some simulations. I mean, if you get a survival curve like this, okay, then this is you see every survival curve has a corresponding hazard curve. And the cumulative hazard is the area under the curve. So if there is a study, a group that has this hazard curve with this, of course, everything is given based on a standard group, which is this one here, the one with a solid line, which is, has a hazard curve of 1. So you calculate the area under the curve and the area under here. So the best way, I think, is to spend a few days to take some sabbatical week or something and play around with these things in order to understand. I cannot figure out a better way to understand hazard ratios. Anyway, for me, it is important the way the studies are reported nowadays is too processed to my taste. I need a little bit of raw data in front of me to be able to understand, because my intuition is not that sophisticated. So what I have tried, what I always try to do is to get back to the raw data and see what it means. And although these tools are very simple, they are very useful because an alternative, although the hazard ratio is the optimal tool that to use in survival studies, there is another concept that is sometimes used that is much more intuitive, which is the relative risk. Okay? Now, the relative risk is a ratio between two conditional probabilities. And conditional probabilities are also, although they are much simpler than the concepts that I have mentioned. Okay, so let's go through this. So I use a 2x2 contingency table. This is a positive intervention. This is a positive outcome, and I'll give you some examples. We have A, B, C, D, 2x2 contingency table. So the probability of a positive outcome, this is the probability of a positive outcome given a positive intervention. So this is a conditional probability A over A plus B. Okay, so this is a conditional probability of a positive outcome given a positive intervention. And this is the probability of a positive outcome given a negative intervention. Okay, and the relative risk is this over this. Okay, the odds ratio is this times this over this times this. But the most useful thing here, and the relative risk is much more intuitive than the hazard ratio, and it is a similar concept, but this is more intuitive. So that's why I like it, even though I recognize that it has its limitations, in the sense that it would not avoid some bias. If there is bias, then it will. And of course, in order to understand the statistical significance, you can calculate the chi-square from this table, which is very straightforward. I mean, this looks like a, but it's not. It's basic calculations. Anyway, now let's go. I'm sorry I had to give this introduction. This is how you get nowadays. I mean, this is a systematic review of what I call an intervention, but it's just a clinical variable, donor-specific antibodies, and kidney allograft outcomes. of course, you know, does the fact that a patient has antibodies affect the kidney allograft rejection or not? And, you know, as you can see, these are forest plots that they call. Here they're using relative risk, and this is the cumulative, and they show this. Okay, this is how the data is presented. Now, let's look a little bit more in detail this by Wilcom study. Okay, so this is what you get in the literature, and I mean, this is what the only thing that honestly you can say when you look at when you see these things is that, well, it looks like there is an influence between having antibodies and kidney allograft rejection. But what is this relationship? So what we have here is that in 480 patients, we have 435 that have no donor-specific antibodies, 45 that have donor-specific antibodies. Of these 45, 33 have allograft survival, and 12 have rejection. Antibody-mediated graft rejection, okay? So if there is no DSA, the probability of having allograft survival is 91%. If there is DSA, 73, the relative risk is 124. By presenting the data like this, you have all the numbers in front of you, and you can intuitively, I mean, you know that this is a ratio of two conditional probabilities, and the conditional probabilities come from here, and you have the numbers in front of you. You know how many cases there are, and for me, this is much more helpful in making rational decisions about the data that is available. Now, this is another study about, you probably have heard that there is a new test available to study whether the antibodies in a patient bind complement or not. And the question is this complement binding properties of antibodies clinically relevant or not? This is a study that just came out a few months ago. I mean, not very, 3 or 4 months ago in the New England Journal of Medicine. Very important paper. Look at it. I mean, here it shows this is a survival curve, and this is very dramatic. This is the black is no. I'm sorry. The black shows that there is no antibodies, and the blue and the red is presence of antibodies, but the difference is that the blue is antibodies that do not bind complement, the red are antibodies that bind complement. So in the previous study, I showed you that everybody, I mean, it's something that everybody has recognized by now in transplantation is that antibodies have to do with graft rejection. But this study, which is very recent, shows that no, only if antibodies bind complement are going to be involved in graft rejection. Otherwise, whether you have antibodies that do not bind complement, and they seem to be the same. So this is what you conclude. So when looking at these curves, survival curves, the conclusions that you can draw are of not numerical or qualitative conclusions. So that's why I like to see this a little bit more in detail, and I use these 2x2 contingency tables. I mean, you understand by now, I always put the positive clinical outcome, so the negative is no survival, and the positive is survival. And I put on this cell the positive, I call it intervention. In this case, it's not intervention, it's a clinical property of the patients. Here is that no antibodies, presence of antibodies. I mean, these are the numbers. And you can see that if there are no antibodies, 658 out of 700, or 94%, will have a graft survival, and 222 over 239, or otherwise 93, will have graft. So these numbers are very easy to understand, and these probabilities, and then this relative risk is the proportion, the ratio between these two conditional probabilities is 1.01, which is nothing, and the chi-square, which shows the significance. I mean, in order to be at the significant level of a p-value of 5%, it has to be 3.8 something, and this is, so it's very low. This is, so what this tells you is, as long as the antibodies do not bind complement, there is no difference. It doesn't matter whether you have antibodies or not. I mean, this is what this study is saying. I'm not telling you that this is what it is. Okay, you have to be careful. I mean, but it seems to be that this is the case. From that point of view, we should all be running and doing complement binding tests for antibodies. I mean, this is very interesting. Okay, now, so look at the chi-square here, 0.36, and look at the chi-square here, 62. What do we have here? Non-complement binding antibodies and complement binding. There is a huge difference, you know, from 93% graft survival versus 55% graft survival. And the relative risk is 1.7. So there is a big difference. Now, since we said that non-binding antibodies and an absence of antibodies altogether is the same, I put together the two things. You see, this is just, the 316 are the patients that had antibodies, complement binding and non-complement binding. And these are the probabilities, the conditional probabilities. This is the risk rate, relative risk. When you include everybody, from 316, you go to 1,000, because here you have all the patients that do not have antibody, many more, but the numbers are very similar. The chi-square goes up, but and the relative risk from 1.7, it goes 1.72, is the same thing. Okay, so this, at least this study, and it seems to be done, I mean, I read it carefully, and it's very sound. It's a good incentive to look into this in more detail. Certainly, I think that complement binding of antibodies should be taken seriously. I'm not saying that we are going to jump right now and change everything we do, but this is a very important paper. Now, going to something else. I'm going to take the liberty of going into an area that I'm more familiar with, which is bone marrow transplantation. I know that here there are not very many of you who do bone marrow transplantation, but the important thing is the concepts that I want to, and some of these things can be used in solid organ as well. So, I mean, actually, particularly this paper, even though it's for stem cell transplantation, I mean, this is the kind of data, I confess that this may be a cognitive problem that I have myself. That I look at these curves and I say, what is going on here? I don't get a lot of information from the, it looks like these guys here are doing better than these, but that's all I can tell. Or these guys, and here you can see all kinds of curves, and anyway, it's a little messy. What they're looking at here, well, this paper is very important because for a long time, in bone marrow transplantation, and also in solid organs, we're saying C typing, C matching is irrelevant. Is irrelevant. Well, it turns out that most of the mismatches, the great majority of the mismatches in C, in HLA-C, are between 0303 and 0304 because of the linkage disequilibrium with B15. So these are the let's look at this. Okay. Yeah, these tables. So they look separate. The mismatches for this particular discrepancy, O3, O3, O3. And this is what in serology is called C9, C10. So classically, for 20 or 30 years, where is Marilyn? Marilyn is there. She will know. she is a representative of the history of HLA. So there has always been a serologic distinction between C9 and C10. And it turns out that when you have this C9, C10 mismatch, which is O3, 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 O4, look at the p-values here. There is no difference. It is comparable. These are the hazard ratios here, close to 1, compared to an 8 out of 8 mismatch. So these are 7 out of 8 mismatches. This is an 8 out of 8. 8 out of 8 is the flat hazard curve that we were looking before. And everything, all this is compared to this. Hazard ratios is always comparing two groups, okay? And you can see that there is no difference here. Now, if we go to other mismatches, it's very significant. So you can be looking at a clinical study that says very clearly, with very clean data, and everything is just perfect, C doesn't matter. Okay? What does it take to find that there is something wrong with that? It takes something that is, I mean, that's why I feel very worried when people dismiss expertise of people who have a lot of experience. Because these useless old people with expertise and no evidence-based medicine knowledge are the ones who figure out who it is this particular mismatch that is responsible, because this is the overwhelming mismatches in C are in this group, and these are the ones that tell you that there is no difference between the two, and that everything else is significant. So HLA-C is significant. Now, there is something interesting here. Look at these numbers, is these p-values here. This is C antigen, and this is also at the serologic level, and this is at the antibody level, at the allele level. The p-values are not significant here. They are not in bold, okay? So you can say, you can jump to the conclusion, well, in C, we need to match at the serologic antigen level. We don't need to go to molecular typing. But what's wrong with that? Look at the numbers here, 761. This is a typical problem of power. You see the trends, okay? It's not below 0.01, the p-value, 0.02, 0.06, you see the trend here? Why are these p-values not as strong as this? It's not because allele level mismatches are not important. It's because you don't have enough cases. That's why the number of cases is important. Okay, let's go quickly through this. It's just, how much time do we have? I have a quarter of an hour. Okay, so these are, you see the p-value? The chi-square. Remember that to get a p-value of 5%, you need like 3.8 or something like that. So this is much lower. This is not significant. The overall, this is overall survival. This is not graft survival. This is overall survival. 39% for complete match, sorry. And this is 41% for this mismatch at this tolerant. The paper was, the purpose of the paper was to show that some mismatches are tolerated. And this is an example of them, because the difference between this has a single amino acid mismatch in an area that is not biologically relevant in the sense that it is not involved in the groove that presents peptides, so it's not biologically relevant. Even, I mean, another important thing, and people classical HLA typing with calling the specificity C9, C10. As a matter of fact, you very rarely see C9, C10 nowadays. Most of the time, you see a combine, but let's not go in that technical detail. Anyway, no difference in this single mismatch. Now, when we look at the chi-square, it jumps up to 21. Remember, 3.8 or something is the P 5% value. So it's much higher. And this, we have an HLA-C mismatch other than this one, okay? Okay. So let's quickly go, because we don't have much time. Another question that has bothered me for a long time. When I started, I mean, I've been doing HLA, but at a research level, looking at peptide presentation and trying to build models to see which alleles present which peptides. It was only in the year 2000 when I joined MD Anderson that I started to do HLA before I was doing clinical work, but in transfusion. I was doing research in HLA, but not clinical work in HLA. It was in MD Anderson when I joined the bone marrow transplant group there that I started. And since I didn't know very much about the clinical aspect of HLA, and fortunately I had the resources to do it, I insisted in typing all the alleles, all the loci. At that time, people were only matching in bone marrow transplantation for A, B, C, and DR. And DQ, they were doing DQ too, but they were not doing DP. They were reticent to do DQ, and they were certainly not doing DRB345. And one of the so I wanted to do it just for my own curiosity what it was, whether they played a role or not. And for many, many years, everybody said, no, there is no role, it's a waste of time, it's a waste of money. Look, it was just last year, after more than 10 years of accumulating data, the NNDP, the National Marrow Donor Program, retrospectively types the patients that are going bone. Even if they didn't do DP, they do it retrospectively, and then they see whether it has an effect. And people have been studying this for years, and they didn't see an effect of what we call low expression loci. Low expression loci. Low expression loci, LEL. Low expression loci include DRB345, DQ, and DP. The problem was, again, I mean, all these studies show clear evidence that they didn't matter. It doesn't matter. It doesn't have an effect. The problem is that they don't have an effect if they look at them individually. But when you look at them as a group, then you see the effect. That's a critical point. So this is how, so evaluating a clinical trial goes beyond the original criteria that I gave you at the beginning. It involves a lot of knowledge that comes from, I don't know where it comes from decades of working in an area. I mean, that's all I can tell you. Anyway, when you look at the mismatches, not individually locus by locus, because that was the standard way in which these studies were done, when you look at them as a group, then look what you see, okay? This is if there are 0 mismatches, this is if there are one or two, and here is there are, so there is a difference. Let's look at that difference in more detail. So if we have 2 or less than 2, okay, the probability of treatment-related mortality or transplantation-related mortality is 56% if there are less mismatches. If there are more than 2, 3, or 4, then it drops. It's not great, but it is, and the chi-square is certainly significant. The relative risk is 1.39. So this is a very important data showing that loci that people were taking for granted we're thinking that it don't matter. And even based on strong evidence, in fact, when you look at things in more detail, do play a role. Okay, now, this is, again, in bone marrow transplantation. Let me see how, I just have a few minutes. I want to leave a few minutes for if you have any questions. The role of antibodies. When I started again at the beginning of, around the year 2000, nobody in bone marrow transplantation were looking at antibodies in patients because they say, well, in solid organ, obviously antibodies do play a clinical role, but in bone marrow they don't because they are immunosuppressed. And anyway, we match at the, we do HLA matching at a level that the antibodies are not typically. So nobody was doing antibodies. And we decided to start doing antibodies, antibody screening on patients. And this is what we found. What we found was that in the absence of donor-specific antibodies, the probability of engraftment was 97%. In the presence of donor-specific antibodies, it was 63%. You know, very significant. Okay. And this was in match unrelated donors, match unrelated donors, HLA match unrelated donors. Oh. In related donors, we found something very similar. No, something very similar. So it doesn't matter, I mean, of course, it doesn't matter whether the donor is related. The important thing is the matching, but there were two studies done on the same subject, okay? So this, to me, shows that antibodies are also relevant. And I think now bone marrow transplant programs are beginning to do antibody screening on patients. Anyway, so let me skip this. Yeah, to end, I mean, this is, I wanted to mention, this is not totally related to anything that we have discussed, but this also, what I wanted to discuss today, I mean, here at the very end, is something that is very important. People are trying to see the relationship, not of whether you have antibodies on clinical outcome, but what they call the MFIs, the intensity of the reactivity of the antibodies. I mean, is it MFI of 2,000, 4,000? And people like to have a specific cutoff point. I mean, and depending on the organ, they have different cutoff points. For liver, I mean, they may have 4,000 or 8,000. For kidney, they have 2,000, whatever. What I want to tell you is you have to be very careful with these cutoff points, okay? This is, I mean, this is not, this is taken for a case that I drew it myself. This is not the output of the program, but I wanted to make it very clear. So this is the reactivity of the antibodies. Typically, they are presented in descending order. This is the MFI, 3,000, 2,000, 1,000, like this. In the colors is the levels of, you see if it's above 3,000 is here, anyway. And you have these specificities here, okay? And if you have the cutoff point here in 2,000 or if it's 3,000, you're only going to report this. If it's 2,000, this. So you're going to report different things, okay? This list I'm going to show you in a minute, okay? Okay, these specificities are the ones that are here regardless of the intensity. Okay, what do we see here? How funny that all these alleles have unique molecular properties. This tells me that there may be something going on, okay? So there is an epitope in this area here, the antibody recognized. Well, an epitope, the way I look at it, is defined by positions in the molecule. The isotype of the epitope is the variance of those positions. These are the variants, the different amino acids at these positions. And these are the specificity of the isotopes in this epitope variant. What we have here in this particular case is these alleles, A25, A26, A34, A43, and A80. And this is a classic serologic specificity that used to be called A10. Okay, now, if you go here and you only report these specificities, you are missing this, and you go along and you choose the donor, you do all your business. You understand what I'm trying to say? So the point that I want to bring up to you is that you have to be extremely careful with cutoff points with MFIs. I think the cutoff points should be a function of because this variability, let me put a metaphor. The MF5, the intensity of the antibodies, is like measuring the height of children with an elastic measuring tape. It's not, I mean, all this is the same antibody. It's not that we have here 6 antibodies against 6 alleles. We have 1 antibody against a public epitope that is present in all these alleles. That's what we have. And when you use arbitrary cutoff points, okay, this is another detail that may be missed in when we do clinical studies. Anyway, I just wanted to finish to give you a chance to ask any questions about this. Yeah.
Very, very interesting and provocative talk. But nonetheless, I think really does point out that we have to really be careful when we do evaluate data and realize the variabilities in those. So, questions?
I have a statistical question. The chi-squares analysis requires that you actually have,
Sorry, the what?
I mean, the 2x2 contingency table. It requires that you distill everything down to 2 comparisons. So if you have multiple things involved in what you're trying to look at, unless you combine data, you can never do a chi-square analysis.
Yeah, you will need to have different, that's what I did in some cases where there are multiple groups, you need to have, yes, in 2x2 contingency tables, obviously, but that's the way I personally feel comfortable looking at 2 things at a time, you know, and concentrating on that. Of course, you need different tables for comparing different things, and I try to do that. But
I tend to agree with you, but a statistician would argue vociferously that you're not able to combine things unless you design your study to combine them.
If you
design your study to look at multiple variables, you can't take a variable and put it together. Statisticians will argue.
Yes. I agree with you.
But
yes.
It makes it much easier to understand.
Yes, what I do, when I look at things, I only look at 2 things at a time because my mind is not designed to go beyond that. But no, I mean, of course, I'm not suggesting that we should do away with the statistician. For complicated things, we should turn to them, but we should not use complicated, sophisticated tools when we can see things clearly. And it is very important for, you know, when we talk to patients, when we try to explain, when we try to make use of the data ourselves, that we understand the numbers, where the numbers come from, is very important. Otherwise, when we do these hazard ratios, yes, it looks like there is something going on here. That's all we can say. That's all I can say. I mean, it's just, yeah.
Other questions? Thank you, Dr. Cano.
Yeah. Thank you.